Objective 45, compare and contrast Rh and ABO incompatibility in terms of pathophysiology and treatment during pregnancy. A little bit of this information is actually in chapter 21 in your book on page 546. Rh incompatibility is also known as isoimmunization. It occurs when the mom is Rh negative and the baby, the fetus, is Rh positive. The pathophysiology behind it is that hematopoiesis in the fetus is well established by the 9th week. When fetal red blood cells that have the Rh antigen, positive antigen, pass through the placenta and for some reason enter into maternal circulation, which is not normal, the maternal immune system produces antibodies against the Rh positive antigen from the fetus. The process of creating the maternal antibodies is called maternal sensitization. When sensitization occurs, the maternal antibodies usually do not affect the first pregnancy. However, subsequent pregnancies will lead to quicker antibody formation, which will lead to destruction of the fetal red blood cells. This will result in fetal hemolytic anemia. The mild fetal complications from Rh incompatibility include fetal anemia and newborn jaundice. However, there is a potential very serious complication. Erythroblastosis fetalis is the more severe form of Rh incompatibility. In the fetus, there will be marked anemia, cardiac decompensation, cardiomegaly, hepatosplenomegaly, hypoxia, generalized edema, ascites, pericardial effusions, and pleural effusions. In the maternal side, there is the potential for a uterine rupture. The treatment of erythroblastosis fetalis includes early birth of the fetus and also possible intrauterine infusions of red blood cells, basically transfusions of red blood cells to replace the ones that are being destroyed by the maternal antibodies. Prevention and monitoring of Rh incompatibility. RhoGAM is given to all women that are Rh negative prior to delivery. RhoGAM actually destroys any fetal red blood cells in maternal circulation and blocks the maternal antibody production to the Rh positive antigen. There's a medication guide on page 547 in chapter 21 that talks about RhoGAM and RhoGAM administration. RhoGAM is given at 28 weeks gestation because at that point in time there is an increased likelihood that fetal red blood cells may transfer across that single cell membrane division between maternal circulation and fetal red blood cells. It's also given within 72 hours of the birth of a Rh positive infant to a mom that is Rh negative. It's also given after any invasive procedure where there's the potential of mixing of maternal and fetal blood, after any miscarriage or abortion, because again we do not know if that fetus was or the embryo was Rh positive or not, and then also trauma or when there's any potential mixing of maternal and fetal blood if mom's Rh negative. We can monitor Rh incompatibility by using an indirect Coombs test. This test is done on mom to determine if an Rh negative woman has the antibodies to the Rh antigen. Blood is drawn at the first prenatal care visit and also around 28 weeks gestation. If there's a positive indirect Coombs test, blood levels are drawn on mom at every 4 to 6 weeks to monitor the titer level of the indirect Coombs test, which will tell us the red blood cell production or actually increase in antibody production against the Rh positive antigen. Here's just a little caricature on RhoGAM. This mom's Rh negative, has no Rh positive antibodies, and we need to keep it that way. So RhoGAM prevents that from occurring. And then the little guy on the right says, you're right, this is an Rh positive baby that can send Rh positive antibodies to moms, and that's bad news for future babies. RhoGAM is given at IM at 28 weeks gestation within 72 hours of a birth of a positive Rh positive infant. If infant is Rh negative, there is no reason to give a shot of RhoGAM. So RhoGAM's process is to help prevent mom from developing Rh positive antibodies that can affect future pregnancies. ABO incompatibility is the most common hemolytic disease of the newborn. It occurs when the maternal blood type is O and the fetal blood type is either A, B, or AB. It has nothing to do with positive or negative. The pathophysiology. ABO incompatibility occurs when naturally occurring anti-A and anti-B antibodies transfer across the placenta to the fetus. and it can affect any babies, including the firstborn infant. The treatment, there's no treatment actually during pregnancy. However, after birth, the newborn cord blood is typed, and there's a direct Coombs test ordered on the newborn blood to determine blood type and Rh. And the newborn is carefully watched for the development of jaundice with ABO incompatibility. Usually, ABO incompatibility is much less traumatic to the infant than Rh incompatibility. Objective 46 says examine the effects of substance abuse on the mother and the fetus. This is on page 330 in your book. Use of alcohol and illicit drugs are well documented with the effects on the fetuses and newborns. And this is in chapter 13. Alcohol and illicit drugs readily pass through the placenta. Women are at greatest risk for developing a psychiatric disorder between the ages of 18 and 45 years of age, and that is basically in their prime reproductive years. Why did I add that in there? Well, it's because sometimes with psychiatric disorders, people use illicit drugs to help calm themselves or help push away the signs and symptoms of the psychiatric disorder that they are experiencing. Risk factors for substance abuse include a history of childhood sexual abuse or physical abuse, a partner that abuses substances, somebody who is unemployed, unmarried, or has a history of experiencing psychiatric disorders. Commonly abused substances in pregnancy include nicotine, caffeine, and yes, I know those two are legal drugs, but they do cross the placenta and do have effects on the developing embryo and fetus. Alcohol, marijuana, cocaine, methamphetamine, and opiates. If you read off to the right-hand side of the slide, this is from the National Women's Health Information Center. When you are pregnant, you are just not eating for two, you also breathe and drink for two. So it is important that you carefully consider what you give to your baby. If you smoke or use alcohol or take illegal drugs, so does your unborn baby. First, don't smoke. Smoking during pregnancy passes nicotine and cancer-causing drugs to the baby. Smoke also keeps your baby from getting nourishment and raises the risk of stillborn and premature birth. Don't drink alcohol. There is no known safe amount of alcohol women can drink while pregnant. Alcohol can cause lifelong physical or behavioral problems in children, including fetal alcohol syndrome. Don't use illegal drugs. Using illegal drugs may cause underweight babies, birth defects, or withdrawal symptoms in the baby. If you are pregnant and you smoke, drink alcohol, or do drugs, get help. Your healthcare provider can recommend programs to help you quit, and you and your baby will be better off. And so we need to, as nurses, ask questions about use of these illicit drugs and also commonly used drugs. If you look on box 13.8 on page 332, dealing with pregnant substance abuse, substance abusers, this is what you need to do as a nurse as your interventions. You can realize that the decision to become and remain sober can only be made by the substance abuser. You can't tell her to do it. She won't do it. If you tell her, it has to be her decision. And understand that nurses do not have the power to cure anyone, but we can be cheerleaders and huge supporters of quitting a substance abuse, a substance that's being abused. Educate yourself and the patient who is pregnant on the effects of drug use in general and the effect of pregnancy and the newborn specifically. You need to treat substance abusers with the same respect and consideration you show to all individuals. You as a nurse need to be familiar with all your local treatment centers and learn which ones are accepting pregnant women that are abusing substances. And practice patience and persistence. It may take months or years to see the effects of your work and you being a cheerleader to help somebody come off illicit substances. Drug testing during pregnancy. The Supreme Court has ruled it is illegal to test a pregnant woman for drugs without her permission. Urine toxicology. Drugs may be found in the urine for days to weeks after ingestion depending on the drug. Meconium and hair analysis is actually a better indication of drug use. Meconium is collected on the baby after it's born. And hair analysis will show you about the last 6 months if there's any abuse within the last 6 months. Dealing with pregnant substance abusers, again using your soft skills. Looking at box 13.8 on page 332. And methadone is the standard of treatment for women that are opiate dependent. Now again, there's side effects of using methadone for the developing fetus and offspring, but it is the standard of treatment instead of having the individual use opiates. Objective 47, recognize the effects of pregnancy on women with heart disease. Because of the cardiovascular changes that occur with pregnancy, any woman with heart disease is at a greater risk for maternal morbidity or mortality during pregnancy and childbirth. Management focuses on preventing hypotension, maternal tachycardia, and optimizing cardiac output, which then will promote oxygenation to the fetus. Every effort should be made to promote oxygenation to the developing fetus in any mom that has heart disease. Nursing management, it's important for you as a nurse to recognize the abnormal cardiovascular signs. If you look on table 13.4, in your book, it talks about the cardiovascular signs and symptoms during pregnancy, what is normal and what is considered abnormal. Bed rest may be indicated so that we don't have straining of the heart, which will lead to congestive heart failure. And you need to be ready to early identify cardiac decompensation. It is very, very important, and that is in box 13.4 on page 316. If you have somebody who has a heart disease and is pregnant, you need to be readily available or readily identifiable the signs and symptoms of cardiac decompensation. Remember, those are going to be extreme cases of cardiac and lung signs and symptoms in the patient. There's also a patient teaching about what you need to teach the patient who has a heart disease and is at risk for cardiac decompensation, and that is also on page 316. Medications are listed in table 13.5 on page 317. They include the cardiac glycoside of digoxin. Anticoagulants, heparin does not cross the placenta, so it is considered safe during pregnancy. We do not use Coumadin because it does cross the placenta and causes potential complications in the baby. As you look, diuretics, beta blockers, vasodilators, calcium channel blockers, and antiarrhythmics, all our category C studies, mean we just don't have the studies on humans to determine if they are safe or not. Animal studies have shown no adverse effects on the fetus, but we don't have any adequate studies in humans.